Hi, my name is Ed Howard. I'm with the Alliance for Health Reform, and I want to welcome you on behalf of Senator Blunt, Senator Rockefeller, our board, to today's program on affordability to consumers among the health plans offered inside and outside the health insurance marketplaces or exchanges. Some of you may have heard that tomorrow, that is November 15th, begins the second open enrollment season for plans offered through the marketplace. That period runs through February 15th, a far shorter period than the 6-month open enrollment time that we had last season. We all know that the marketplace has had some major problems with aspects of their operations. I'm sure we'll hear some about that today, as well as hearing about the steps being made to improve that functionality. And we also want to look closely at the affordability part of the Affordable Care Act. There's a new issue brief in your packets that describes how much people had to pay for private insurance last year and the impact that spending had on those doing the buying. Now, the rates for 2015 have only recently become available, and we'll explore what consumers looking to renew their insurance or seeking insurance for the first time will encounter in these next few weeks. We're very pleased to have as partners in today's program the Commonwealth Fund, a century-old philanthropy established to promote the common weal or the common good. And we're doubly pleased to have as our co-moderator today, Sarah Collins, the Fund's Vice President for Healthcare Coverage and Access. She also happens to be the principal author of that impressive issue brief I mentioned. It's in your packets that has findings from a new Commonwealth survey on out-of-pocket costs in the private insurance market. And in addition to moderating with me, Sarah has some important information to share with us in just a moment from that survey. Now, before we turn to Sarah, let me tend to a little housekeeping. As you can see on the screen, if you're in a Twitter mode, you can use the hashtag OE2, that is not a new ocean liner or a new Fed plan to float the economy. It is open enrollment second year. In your packets, you'll find some important information, including speaker bios, more extensive than the intros that you'll hear from us today. You'll also find a one-page materials list, the PowerPoint presentations that our speakers will use, and lots more background is available for you on our website, which is allhealth.org. There'll be a video recording of the briefing available probably Monday, followed by a transcript a couple of days later on that same website. Also, you can find the speaker slides, digital copies of the background materials, and those of you who are watching on C-SPAN, you can find all of that information and follow along by going to allhealth.org. I should say to the audience here that C-SPAN coverage is not live today, so check the broadcast schedule. We know that it'll be on Sunday at 4:25 p.m., so instead of that second NFL game, come look at this fabulous program that we're about to put together. And there'll be other airings as well. One other thing I just wanted to mention, there are a couple of pieces of paper in your packets that are of importance for you to keep in mind. There's a green question card that you can use to write a question and have it brought forward when we get to the Q&A. And there's a blue evaluation form that we plead with you to fill out because it helps us try to respond to the ways in which we can improve these briefings and make them even more useful to you. Now, let's get to the program, and let's start by hearing from Sarah Collins, who not only can offer the greetings from the Commonwealth Fund, but can also share with you the results from the new Commonwealth Affordable Tracking Survey. Sarah, good to have you back.
Thank you very much, Ed. And on behalf of the Commonwealth Fund, I want to thank the Alliance and thank the panelists for coming today, and also to extend a warm welcome to the audience. I'm going to spend just a few minutes discussing the premiums of the plans that are going to be sold through the marketplaces this year, at least some preliminary information about what we have about them. That's going to come really quickly with open enrollment starting tomorrow, and how they compare to plans that were sold last year through the marketplaces. And I'm also going to look at the deductibles of these plans. There has been a lot of focus on premiums, and I think and less so on the deductibles and cost sharing. And then, as Ed mentioned, I'm going to share with you some findings from a couple Commonwealth Fund surveys that's asked what consumers think about their premiums, about the affordability of their plans, as well as what their out-of-pocket cost responsibilities are. As Ed mentioned, open enrollment begins tomorrow, and it goes through February the 15th. And Mina Shashimami and Tim Jost are going to help us understand the details of that from a couple of different perspectives today. This week, consumers were able to go online and visit the website healthcare.gov and browse their 2015 health plan options. So I went online and I entered the zip code where I grew up in Memphis and entered a random age, 40, which is not my age, and a random income, and hit the button that says continue to plans, and this is what popped up on my screen. 106 health plans available for enrollment in Memphis. But I experimented in the browsing feature by plugging in different ages, different incomes, and the displayed premiums all adjusted based on the information that I fed the site. So for people with incomes under 400% of poverty who are eligible for the premium tax credits, the amount of the credit is displayed, and then it's applied automatically to the plan options, so it's easy for people to see what they're going to pay. But it's really critical that consumers also look at what their cost sharing is going to be over the course of the year in their plans, looking carefully at what the deductibles are and the copays are. And it's also critical that consumers who have incomes under 250% of poverty, which is about $30,000 for an individual, know that they're eligible for cost-sharing reductions that lower their deductibles and their copays. These reductions are also applied automatically on the screen when someone in that income range is browsing their plans. But in order for those reductions to apply, you actually have to choose a silver plan. This analysis is by John Gable at Newark, which shows average premiums for silver-level plans available in marketplaces this year in 4 states that had final rates available for him to look at, and how they compare to last year. It also computes average deductibles. In this analysis, the 2015 premiums declined in 2 states from 2014 and increased moderately in 1 state, Nevada, and less moderately in Minnesota. These are patterns that we're seeing across the country. If you look at the last 3 columns on the slide, there are similar changes in average deductibles. So in Minnesota, where premiums rose somewhat more than other states, if you look at the average deductibles in that state, they actually fell by the same amount. So an increase in premiums of 14%, and a decline in deductibles of 14%. It's also really important when you look at these rates to keep in mind that these are non-subsidized rates. So in Connecticut, for example, if you look at the second row in the slide, a 40-year-old man making $18,000 a year would receive a tax credit of about $270, which reduces his premium to about $65 for the plans that are shown on the slide. So how do we evaluate the affordability of these plans in premiums and their potential out-of-pocket costs for people? One way is to look at how they compare to what people pay when they're enrolled in plans through an employer. So in the Fund's Affordable Care Act tracking survey that we fielded at the end of the open enrollment period this year, we asked people with both marketplace plans and employer plans how much they paid in their premiums. So adults with incomes under 200% of poverty, which is again just under about $30,000, with marketplace plans paid monthly premiums that are comparable to those paid by adults with employer-based coverage. So this indicates that the marketplace premium subsidies this year helped equalize the affordability of individually purchased plans and employer plans. This was not the case prior to the Affordable Care Act going into effect, when people in this income range were effectively shut out of that market because of how expensive the plans were. But as you go up the income scale, the tax credits decline and people pay more of their premium for their marketplace plans. This is not the case for employer plans. Most people who have employer-based plans pay the same amount regardless of what their income is. We asked people in the survey with marketplace plans and employer plans how easy it was or difficult it was to afford their premiums. People with lower incomes with marketplace plans reported finding it easy to afford their premiums at similar rates to those who had employer coverage. But people with higher incomes were significantly less likely than those in the same income range with employer-based plans to say it was easy to afford their premiums. We also asked people about their deductibles. As I mentioned, people with incomes under 250% of poverty who purchase a silver plan are eligible for subsidies that lower their deductibles and their copays. So in the survey, adults with incomes under that range with marketplace plans had deductibles that are comparable to those in employer plans. Adults with higher incomes, if you look at the bottom set of bars, with marketplace plans faced higher deductibles than people with employer-based coverage. A new survey that Ed mentioned that's in your brief. It features findings from a new survey that we're doing on how affordable healthcare itself is for people. We're calling it the Healthcare Affordability Tracking Survey. And again, we looked at people with all types of insurance coverage to get a read on what consumers in general are spending out of pocket for their health care. We know that in all types of insurance, deductibles and copays are rising, and we want to know how these trends are affecting consumers. We asked people with private coverage, both employer and individually purchased coverage, who had a deductible, how easy it was to afford it. 43% of adults with private insurance said their deductibles were somewhat or very difficult to afford. About 3 of 5 adults with low incomes and half of those with moderate incomes said their deductibles were difficult to afford. We also asked people whether their deductibles had affected their medical decisions, so whether they had done anything with respect to their health care because of the size of their deductible, such as not going to the doctor when they were sick, not getting a preventive care test because of their deductible. 40% of people with deductibles that were high relative to their income said they had not gotten needed care because of their deductible. Just to wrap up, the marketplaces in 2015 are shaping up as stable and competitive. The premiums have increased this year moderately or in fact have declined in many states. The premium tax credits and cost-sharing reduction subsidies were critical this year in reducing both premiums and deductibles for lower-income families. But current trends towards higher deductibles and copays across all forms of insurance may leave many people with high out-of-pocket cost burdens. The reforms of the Affordable Care Act are improving affordability and will help reduce underinsurance across the country. But the underlying rate of growth in U.S. healthcare costs, which drives growth in both premiums and deductibles, will be a significant factor in consumer healthcare cost burdens over time. We're lucky to have Dan Durham here today, who's going to discuss some efforts underway to address that challenge. Thank you, and I'll turn this back over to Ed.
Great. Thanks very much, Sarah. And let me give the merest of introductions to our very distinguished panelists. We're now going to turn first to Dr. Meena Seshasmani, who directs the Office of Health Reform at HHS. She's a head and neck surgeon by profession, and now she tends to HHS's reform implementation, including delivery system reform. Then we'll hear from Dan Durham, who, as Sarah noted, is from America's Health Insurance Plans, or AHIP. He's the Executive Vice President for Policy and Regulatory Affairs. He's held senior positions at the Social Security Administration and at HHS, and now he guides AHIP's reform and policy efforts. And the final speaker will be Professor Tim Jost from the Washington Lee University School of Law. He's the author of highly respected text on health law, so as we say, he literally wrote the book. And he's also a consumer representative to the National Association of Insurance Commissioners. and a prolific and insightful blogger, and we're glad to have him back. So let's turn first to Mina Seshomani from the Office of Health Reform. Mina, thanks very much for being with us.
Thank you for having me. It's a pleasure to speak with all of you today. So I thought what I would do is first go over kind of where we are on the eve of the start of Open Enrollment 2015, and then talk a bit about Open Enrollment 2015. There we go. So first, again, looking at 2014 and then moving to 2015. So first, just some basic facts about where we are today. So we're actually at 7.1 million Americans are enrolled and have paid their premiums. About 8.7 million additional people have come in through Medicaid and CHIP since October of last year. Importantly, one of the things that we learned through outreach in 2014 was the importance of media, enrollment events, having navigators and in-person help, and that generated calls to the call center, visits to healthcare.gov, et cetera. So some lessons that we learned in 2014, which we are applying for this current open enrollment period. First, the combination of paid, social, earned media, grassroots outreach, all of those things together drive enrollment, particularly when you have key dates and messages that are reinforced across all of these channels. And what are some of those key messages? Well, talking about testimonials, people who have successfully come in, been able to get insurance, are happy with their insurance. Deadlines, people respond to deadlines. And also talking about affordability and particularly the availability of premium tax credits for the majority of people who come into the marketplace. Also of importance is follow-up, making sure that we chase people who do come into the system, using digital media, and again, focusing on regions, local partners, because that's where people tend to obtain much of their information. So now just some basics on the Affordable Care Act, where we have come to date. And we tend to look at evidence that the ACA is working across three buckets: affordability, access, and quality. So I'll walk briefly through each one. First, the ACA is making healthcare more affordable. Consumers have saved $9 billion since 2011. Part of this is through the medical loss ratio provision that requires that 80% of premiums be spent on medical claims as opposed to administrative costs, and if not, families get a rebate. The average rebate in 2013 was $80. We've talked a bit about the premium tax credit. In the last open enrollment, nearly 7 in 10 consumers who selected plans got covered for $100 a month or less, and nearly half, it was $50 a month or less. Employer premiums grew just 3% in 2014, tying it with 2010 for the lowest on record for more than a decade. The law is also making coverage affordable to small businesses with tax credits and through changes in the rating to prevent a small business from having a large premium increase if one of their employees falls ill. And importantly, hospitals will save an estimated $5.7 billion in uncompensated care this year, and particularly in states that have expanded Medicaid, but also in other states as well, again, hearkening to the improvement in coverage. In terms of accessibility, the New England Journal of Medicine found that there were 10.3 million fewer uninsured Americans since the start of open enrollment, which was a decline of 26%. And along with accessibility in terms of being able to obtain coverage is the choice that you have. And in 2015, there are 25% more issuers selling health insurance plans in the marketplace in 44 states. So along with choice, another aspect is what kind of coverage is able to be obtained. And now 76 million Americans are eligible for preventive services, vaccines, cancer screenings, wellness visits without cost sharing, including 30 million women and 18 million children. And again, talking about what coverage people are able to get, there are no exclusions for pre-existing condition, no lifetime limits on coverage, which are also significant consumer protections. Here, this is talking about Medicaid expansion. So as you know, it is a state option. This is a map that provides you all of the states that currently have expanded Medicaid. Now moving to quality. to cite the Commonwealth Fund, a survey showing that more than 3 in 4 newly insured consumers express satisfaction with their coverage. And there has been significant work towards improving access to quality care for Americans, including reducing harm nationally, such as fewer healthcare-associated infections, which leads to not only better health, but also reduced cost in terms of treating those complications. 150,000 fewer unnecessary hospital readmissions. Movements in the electronic health record sphere, with now 75% of eligible professionals and 92% of eligible hospitals involved. And also demonstrations such as accountable care organizations, where providers have benchmarks on quality, patient experience, and on how they're able to more efficiently use resources. And these have saved $372 million. So now I'll turn to talking about open enrollment in 2015. As you probably all know, it begins November 15th, tomorrow, and ends February 15th. If someone enrolls by December 15th, their coverage will start January 1st. This year, importantly, we'll be focusing both on re-enrolling consumers from 2014, as well as enrolling new consumers for 2015. And just to note that in Nevada and Oregon, consumers will have to come back in because they switched. I think Dr. Jost is going to be talking more about renewals and auto-enrollment, so I'll go ahead and just kind of gloss over these 2 slides a bit more. But basically, there are a series of notices. We are encouraging people to come back and shop. As I mentioned, 25% more issuers means more choices for people to be able to find a plan that fits their budget and their needs. And that is really one of our driving messages for people. And we have a fact sheet with 5 steps to staying covered, again, to encourage people to come back in, update their application, and shop for a plan. So just a little bit on our resources for open enrollment in 2015. As I mentioned, in-person help is critical, and building the assister community is very important. There are assisters available in every state to help consumers get help when they're applying for and choosing new coverage. And these assisters consist of navigators, non-navigator assisters, which are just getting funding a different way, certified application counselors, and agents and brokers. And for 2015, HHS awarded $60 million in navigator grants to 90 organizations, and we're actively recruiting certified application counselors, especially those with bilingual capabilities. We want to make sure that we have good language access. And as some of you may have seen recently, Experian Language Line went online with access to 200 languages. And we have assister training available at our website. Just a little bit on other aspects of our education. It is important not just to have people come in, shop, get a plan that suits their needs, but also to educate and assist in terms of how they can best use that plan. And that's what Coverage to Care is. It's an initiative designed to help people with their new health coverage, because as you can imagine, a lot of these people may not have had health coverage before and are not familiar with terms like co-payments and deductibles and coinsurance, and what is a primary care physician. So this initiative helps them to understand their benefits, connect with the primary care physician, understand which preventive services are right for them, their written resources, videos, and we also have information online. So very briefly, just some things of what's new in 2015. As some of you may have seen, the window shopping is live. There's a streamlined application. It's simple. Consumers only have to enter information once, and it saves the data as the consumer moves through. Now there are fewer screens. Last year there were 76 screens that many consumers had to go through. Now it could be only 16, and it's more intuitive. The Small Business Health Options Program is coming online as well, available to 50 or fewer employers with 50 or fewer employees. This offers a choice of plans to help with making informed choices, and also a small business tax credit is available worth up to 50% of employers' premium contributions. And so just some parting things for 2015, the renewals and auto enrollments is certainly a large focus for us. Again, the increased choice, I think, is key. Provider network transparency, didn't get a chance to talk about it much here, but when people shop for plans, there will be a link for them to look at the provider directories, the coverage to care I talked about, and also with tax season coming up, one of the things that will be coming into effect is the shared responsibility fee. And thank you again.
Okay, thanks very much, Mina. We'll turn now to Dan Durham from AHIP.
Well, good afternoon, and thank you, Ed and Sarah. I look forward to talking about where we are in terms of results and expectations, and hope to have a lot of good questions and discussion among the panel members today. I'll focus on health plan's top priority, delivering value to consumers. American families want value for the money that they spend on their premium dollars. They want affordable, quality coverage. And they want choice. Bronze to platinum, tailored networks to broader provider networks. Health plans are delivering what consumers want in a very competitive market. They're delivering affordability, value, and choices that meet consumers' needs. Health plans are delivering value by negotiating the best price for health care services and by collaborating with providers to ensure quality care. However, there are some major challenges in health plans' effort to deliver value to consumers. The most significant challenges arise when the market for services is not competitive. For example, while the rhetoric behind hospital consolidation is about efficiency, the reality is higher prices for consumers. The FTC has been very clear on this, as have many studies in peer-reviewed journals. The Robert Wood Johnson Foundation study found that consolidation trends increase cost by as much as 20% with no countervailing increase in quality. Another significant challenge, high-priced specialty medicines that have no competitors, no leverage for health plans to negotiate a lower price for consumers. The latest to hit the market is Harvoni at $1,125 a pill, $95,000 for a 12-week course of treatment for hepatitis C. Reasonable incentives to develop more effective medicines are appropriate, but $95,000, really? Is that reasonable? With many more high-priced specialty medicines in the pipeline, this is clearly not sustainable for consumers that depend on Medicaid, Medicare, and private health insurance. In a 2008 Health Affairs article, Joe Newhouse and Richard Frank called this type of pricing patent protection on steroids. Their solution, binding arbitration. What's pharma's solution? Put price controls on other stakeholders and ignore the price of the drug and their responsibility. In fact, the ACA includes limits on what consumers have to pay out of pocket. Today, 6% of $95,000 is what a consumer enrolled in a silver plan pays out of pocket for a 12-week course of Harvoni. The plan pays 94%. Individuals with incomes of $17,500 or less pay 1%. The plan pays 99%. Why? Because the average maximum limit on cost sharing for silver plans is $5,730, and it's $1,100 for those with incomes of 150% of the poverty level or less. Clearly, the reform market limits consumers' out-of-pocket expenses, but it does not protect them from monopolistic pricing that drives up their premiums. So what's the real problem here? The cost sharing or the price? Well, despite these significant limitations from markets that are not competitive, health plans are doing all they can to deliver value to consumers. We all agree that we have to stop paying for volume and start paying for value. And that is exactly what health plans are doing. This consumer-driven, value-oriented market is here to stay. 40% of health plan payments are now tied to value, and this percentage is continuing to grow. The breadth of innovation is considerable with our health plans. You can see it on this map here. Across the nation, health plans are driving innovation to deliver value to consumers. We're building on this tool, this map, so that policymakers, reporters, and consumers can see what's happening in their markets. So what are the results? This slide provides a few examples of how health plans are delivering value to consumers, and we have many, many more. Medical homes. Anthem's patient-centered medical home program has resulted in a 15% reduction in medical and pharmaceutical costs, and quality of care was maintained or improved. Care First has lower hospital admission rates and significant overall savings. Accountable care. Aetna's collaborative accountable care relationship with Nova Health, which is a physician association in Maine, has improved quality care at lower cost. 45% fewer hospital admissions and 56% fewer readmissions. Cygnus programs across 24 states are seeing lower cost and fewer emergency room visits. And with oncology, United's bundled payment, their approach saved $33 million without any reduction in quality. And importantly, we are helping patients engage with their care. We have cost calculators that help them compare the cost of procedures and the quality of those providers that provide those procedures. We have mobile applications that provide important user-friendly healthcare information to consumers. These efforts and many more drive value by providing consumers with the tools and resources they need to make informed decisions. And we are delivering value and choice to consumers through health plans competing on the exchange. The results? High consumer satisfaction. Just look at today's Gallup poll. And clear choice in high-value networks, designs that meet the needs of consumers. According to McKinsey, 90% of individuals have access to broad networks, and 92% have access to more tailored networks that deliver quality care with significantly lower premiums. Do we want to take that choice away from consumers? Well, they just did in South Dakota, where a physician-owned specialty hospital succeeded in passing a ballot initiative on any willing provider. This destroys the value proposition, and the FTC has been very clear. AWP laws harm consumers. Health plans are focused on 5 areas to bring even more value, affordability, and stability to consumers. First, ensuring providers have access to the right information to make the right decisions for their patients. We need effectiveness and value data that all stakeholders can use. Second, alignment and integration across the entire system, from partnerships with providers to removing unnecessary barriers to care from high-quality providers. Health plans are leading the way, and we are building on what works. And then third, transparency. The only way for all of this to work is if we give consumers and providers access to the best information to make informed decisions with their care. So in conclusion, we have come a long way since the passage of the ACA 4 years ago, but we have a lot of challenges ahead of us. Health plans are doing their part to be leaders and innovators to meet these challenges. From provider partnerships to equipping consumers with critical tools and to innovative delivery models. Health plans are changing the game of healthcare delivery to bring value to consumers. That's the bottom line, and that's what we'll continue to do. Thank you, and I look forward to our discussion.
Okay, thanks, Dan. Let's, if I can trouble you for the clicker that will allow Professor Jost to move his slides along. We'll turn to Tim.
Thank you, and thank you for inviting me today. I think you'll be able to tell by looking at the slides which of us work for the federal government or major corporations and associations and which of us work out of a little office off of our bedroom. Tomorrow, the marketplace will open its doors for 2015. The door will stay open through February 15th. During this 3-month period, it is hoped that 3 to 5 million Americans will sign up for coverage for the first time. It is also hoped that most of the 7 million Americans currently covered through the marketplace will re-enroll for the second year, making a significant further dent in the number of Americans who remain uninsured. And I just say that the numbers I have in the slides are from the CBO report. As I'm sure you noticed, the ASPE put out a report this week with somewhat lower numbers. The re-enrollment process will vary somewhat between the federally facilitated exchanges and the various state marketplaces. Those covered through the federally facilitated marketplace should by now have received a redetermination notice from CMS. This notice will be worded somewhat differently depending on the situation of the enrollee. Those who received tax credits for 2014 and authorized access to their 2013 tax returns will, if those tax returns do not disclose an income close to or above the eligibility level, be encouraged to return to the exchange and update their eligibility information. If people do not return and update, they will simply receive the tax credit in 2015 that they received in 2014, which will in turn be based on their 2012 tax returns. Enrollees should also by now have received a second notice from their insurer advising them to re-enroll for 2015. In most instances, it will tell them that they will be re-enrolled in the same plan that they were in for 2014 or a similar plan if they do not go back to the marketplace and choose a different plan. 2014 enrollees should return to the marketplace for 2015. First, they need to make sure that their eligibility information is up to date. Over the course of the year, there may have been changes in their income or household composition, and these need to be reported. Moves, qualification of a household member for other health coverage, and changes to immigration status or incarceration of household members should also be reported. If further changes are expected in 2015, these should also be disclosed. Although 90% of the information on the online reapplication form will be pre-populated, enrollees need to check every item on the form to make sure everything is up to date. Enrollees who fail to return to the exchange may well receive smaller advance premium tax credits than they are entitled to in 2015 if premiums may have gone up more than income. On the other hand, enrollees who have seen large increases in their income or who have had members of their household move out or age off of coverage may receive more in tax credits that they're entitled to and may have to pay back sizable amounts when they file their taxes in 2015. Enrollees should also return to the exchange to shop for plans rather than simply being auto-enrolled in the same plan. The total number of insurers offering plans in the marketplace, as we've already heard, is increasing by a quarter, with new entrants in 3/4 of the states. As we've already heard, premiums are going up significantly for some plans, but remaining stable or even dropping for others. Advanced premium tax credits are based on the cost of the second lowest cost silver plan, but plans that may have been the second lowest cost or lowest cost plan for 2014 may cost significantly more in 2015, while other plans may cost less. Of course, premium tax credits are not the only consideration that re-enrollees should take into account. Cost sharing is also important, as Sarah has said. Those with incomes below 250% of poverty who qualify for cost-sharing reduction payments must purchase a silver plan, even though it costs more because bronze plans do not qualify for cost-sharing reductions. Moreover, some insurers are offering plans with basic benefits outside the deductible that offer much more value to those who need little care, and consumers should be looking for these. Consumers shouldn't just assume that they need to pay $2,000 or $3,000 or $4,000 before they get anything at all. It is also hoped that information on networks and formularies will be better this time around, and consumers should consider carefully whether they do better with a plan with a narrower network that is less expensive or with a more comprehensive network which is likely to cost more. Of course, an enrollee who wishes to stay with the same plan can do so, simply entering the plan number that will be included in the re-enrollment number, a notice from the insurer when they go online to update their eligibility information. It's vitally important that enrollees return to the marketplace within the first month of open enrollment by December 15th to update their information and re-enroll to ensure that they have continuous coverage beginning on January 1st for 2015. But enrollees can change plans anytime up till February 15th when open enrollment closes, or even beyond that if they qualify for a special enrollment period. As we've already heard, the enrollment process has been significantly streamlined for most enrollees and should go much more smoothly this time around. But much of the low-hanging fruit has already been plucked, and new enrollees will be harder to find. A recent Kaiser Health poll found that 90% of the uninsured were unaware that the open enrollment was opening again this month, and 2/3 of them knew little or nothing about the health insurance marketplaces, and over half didn't know that they could get financial assistance through the marketplace. Many will face language barriers, and we may well face a more hostile political environment following the election where negative messages have dominated the airwaves. It's rare that you have to go out into a market to sell a product with a torrent of advertisements opposing your product. One factor that should not, and this is important, should not deter new enrollees from enrolling or old enrollees from re-enrolling is the Supreme Court's grant of certiorari this week in the King case. If the court invalidates the IRS rule allowing federal exchanges to grant premium tax credits, its decision will only have prospective application. Individuals enrolling now will not have to pay back credits that they receive before the court reaches its decision. And I quote from a recent Supreme Court case, "The Internal Revenue Code gives the commissioner discretion to decline to apply decisions of this court retroactively." Most individuals with offers of employer-sponsored coverage will not have the option of choosing premium tax credit financed coverage instead. Some low-wage employees for whom coverage is not affordable, however, or employees who are offered coverage that does not meet minimum value requirements, such as not covering hospital services, and we got a clarification on that last week, may be able to choose marketplace coverage instead. Other employees are able to choose among plans through a private exchange. Still others are offered employer coverage but may be eligible for Medicaid, or their children may be eligible for CHIP. Employees of small employers that sign up for the SHOP exchange will be able to offer employee choice in 2015 for the first time in many states. And employees must also then carefully consider coverage that offers them the maximum value. While progressives often focus on access as a key value in health policy, conservatives and libertarians often focus on choice. The Affordable Care Act not only offers health care access to many who previously lacked it, but also offers unprecedented choice. Consumers must be informed and educated, however, to fully exercise their choice opportunities and to exercise them wisely. Thank you.
Great, thanks very much, Tim. Even those of us who have a pretty good understanding of the way insurance works sometimes get confused with all of the different factors that are involved in all of this. So I really appreciate the panelists putting it in words that most of us can understand anyway. And I would ask that you now join the conversation. Those of you here closer to the front are going to find it easier to maneuver your way to one of the microphones that are up front here. There are also, I remind you, the green cards in your packets that you can write a question on, and it will go forward. And before we go to that portion, I wonder if we could just go back to something that was mentioned in Mina's presentation, at least briefly, and then Tim, you talked about it as well. That is the redetermination process. We're talking about figuring out for people who are already enrolled and getting a federal tax credit that lowers the cost of their premium, what the next year's cost is going to be, and what impact that's going to have on their spending. How important is that, and what kind of advice can you offer to those in that situation? You talked a little about a second lowest silver plan that might not be the second lowest silver plan. Who cares about that?
You want to take that, Mina? Maybe I could respond briefly, and then Mina could supplement. The premium tax credit is, the formula is basically that you look at a person's modified adjusted gross income, and then depending on where that lies on a scale between 100 and 400% of poverty, they have to spend a certain percentage of that on their premiums before they get any help through the premium tax credit. The amount they get, though, however, is usually not based on the actual premium they pay, but on the premium of the second lowest cost silver plan that would be available to them in their geographic area, given their family size and the ages of their family and whether anybody smokes. Actually, smoking is not a factor. And so if you were in the second lowest cost silver plan this year, or the lowest cost, you would be getting the maximum assistance. If, however, you were in the second lowest cost silver plan this year, but your premiums went way up, and it's no longer the second lowest cost silver plan, or someone else has undercut the premiums of the plan you're in, and it is now the second lowest cost silver plan, your share goes up, the share that is covered by the premium tax credits goes down. And so it's really important. Now, it may be that people want to stay with their plan, and it may be that the difference is not that great, but it's a factor that people should be aware of so that people can maximize the amount of tax credit that they receive. We all like to get big tax subsidies, right? And also minimize the amount of premium they have to pay.
So even if you had a plan that you liked and it worked for you financially last year, you really should be going back to shop to see what's available this year.
Yes, I mean, you may decide to stay with the plan, and there are, of course, other considerations, cost-sharing networks, formularies, service, quality, but at least it's a factor people need to take into account.
Okay. Yes, go right ahead.
I'm Dr. Caroline Poplin. I'm a primary care physician. I'm also a Medicare beneficiary. For Dr. Shamani and Mr. Jost, you've all been talking about choice and this wide choice that consumers have. Now, Part D gave consumers a lot of choice, and what studies have shown is that consumers don't know what to do with the choice, that they're bewildered by more than 3 or 4 choices. If you look at the Federal Employees Health Benefit Program, which I'm also on, there's also a choice there. And in fact, I think most people stick with what they have because it's just too complicated to deal with all the choices. And have you factored this into the way you're going to roll out the plan or help consumers, or in the design of how the marketplaces set these choices up for people? In healthcare, choice of provider works very well. Choice of plan has not worked very well, at least in those 2 instances.
Well, there's a couple of different ways of addressing that. One is to either standardize plans, and
Right.
Some states have done that, so that and of course the Affordable Care Act went a long way towards standardizing plans by at least coming up with a minimum benefit package and standardizing cost sharing by metal level. You can imagine what it would be like if every insurer could come up with any kind of cost sharing combination and any kind of combination of benefits. We'd be looking at tens of thousands of plans. But at least it's standardized to that extent, and some states are going further in standardizing. The other approach, however, would be to come up with tools that help consumers shop. And Consumer Checkbook, of course, has a tool like that for the Federal Employees Health Benefits Program. They've developed a tool that would work on exchanges. I've heard of other companies that are looking at that kind of tool. And I think that would be tremendously beneficial to consumers if you could simply put in, these are the kinds of drugs I'm using, these are the providers I use, these are the kinds of costs I expect to incur over the next year, these are conditions I have, and then it could direct you to 3 or 4 plans that would be best for you. So I think this is an area where we need to grow, either in further standardization or in further shopping tools. But I agree, right now 106 plans, that's an evening's work trying to work through that.
Even 46 plans.
Yeah.
But I think the point that you made about there are these metal levels that divide out plans based on how much cost sharing there is helps with that. And being able to, through the window shopping as Dr. Collins showed, being able to see in a standardized way and put plans up side by side to be able to compare, I think is important. And lastly, one thing that wasn't mentioned is in-person assistance, call center, navigators, and all of our outreach attempts to help people, and all of the information available on the website, through local partners, through pharmacies, through physicians' offices. I think all of those together can help with the consumer education as well, so that the choice is a reality.
And also, of course, agents and brokers.
Yes, and agents
a
and
lot of them are
Yep.
out there to help and are eager to help.
Thank you.
And actually, that triggers a follow-up, if I can. There have been stories in the national press the last couple of days describing the outreach effort that the administration is involved in as, low-key, I guess was the characterization, and being done with fewer resources. And I wonder whether you think those are fair characterizations, and how are you trying to maximize the impact that you have?
I would say that now that we have 1 year of the outreach under our belt, we learn from it. We're smarter because of it, where we can target. We have relationships that were established last year that we can continue to utilize and leverage and build upon. And in my presentation, I mentioned that one of the messages that works very well are testimonials. Well, we have 7 million testimonials now. I mean, we have lots of people who have obtained coverage to the Commonwealth Fund report, who are satisfied with their coverage. And these are all additional resources that we have this year that we didn't have last year, that we hope to leverage in conjunction with all of our partners.
Okay.
Thank you.
Hi, Carl Schmidt with the AIDS Institute. I have a question about transparency in formularies. You talked about the benefits, hopefully this year, of the transparency in providers. And in your letter to issuers for 2015, you said that there would be, every plan has to have a formulary with tiering, one URL, and also on healthcare.gov website. So I've been using your great function this week, the shopping function. And some are really good. Some were good last year, some of the plans. But we're still finding a lot of them just go to their main website to get the formularies, and we still can't find them. They still have 2014. There is a better summary on the health reform, healthcare.gov for each plan, for more plan information. None of them have, that I've seen, have the formularies yet. It says NA. I guess that means not available. So I guess the question is this, has this practice, this letter to the issuers, are you still going to be mandating that? We hope so, because patients really, to make a choice, do have to get this information. I was able to ask someone from HHS the same question yesterday, and they said, well, it's up to the insurance companies as well. So I would also ask they said that they are the ones who provide the information to put it online, and you did talk about the need for transparency. So it's really a question for both of you. Thank you.
Sure. Thank you. Appreciate the question. And health plans, when they submit their filings to HHS for review, have to fill out incredibly long spreadsheets that include all the drugs that they have. So CMS can review that, check to make sure there aren't any outliers, and ensure that it meets the requirements, both in the statute and with regard to the regulations and other requirements that are placed on them through CSIO. So health plans are doing that, or they wouldn't get approved. In terms of access to those formularies, they have to provide that, either on their website, and you mentioned some have very good search tools, or through other means, sending out a paper copy and the like. That is very important to consumers, to shop, that kind of transparency. I'll also add that I had the pleasure of working at HHS on the Part D program, the Medicare Prescription Drug Benefit, and I headed up several of the implementation teams. And it was a challenge to get things to where they are today. And we've seen in states where they tried to put too many bells and whistles on their platforms, things didn't work. And so just like in the Part D experience, which works very well today, I think we're going to see continued improvements in terms of what new features CSIO and HHS will bring in over time, just like happened on Part D. So it's a work in progress, and it's only going to get better.
I mean, I think I would just echo that transparency is very important, and so that's something that we will continue to work on.
Okay, thank you.
Dan, your presentation mentioned that AHIP has been making a point of dealing with plans in the area of provider directories, and we've been doing some programming on narrow networks in which the question has been raised about directories that are out of date, providers who were in the directory accurately but were stricken from the rolls in mid-year without the opportunity for the consumer to get out of that. Talk a little, if you would, about the steps that you've been taking and how much progress you think there has been from last year to this.
Well, there's been a lot of progress there. Our plans are committed to transparency, and we're committed to ensure that consumers know what they're buying and can figure out if their physician is in the network for the plan that they're purchasing. That button is right there on healthcare.gov where you can go to the directory. Plans work night and day to keep those directories up to date, but there are challenges here. It's a two-way street. Providers have to engage in this as well. You know, we have situations where some providers simply stop taking patients, but they don't inform the plan. We can't update the directory unless we get accurate information from the providers. That is critical too. So I think there's a role here for providers to engage to make sure that they are up to date as well, so health plans can label them correctly in terms of who's in the network and who's not.
I also wanted to add to that. So part of what people will be deciding this fall is whether to switch out of their current silver plan if it's not the second lowest cost plan anymore. And a critical piece of that decision is going to be whether their providers are in their network. And so having that information correct is going to be is actually a really important part of the competition aspect of the marketplaces. So it's not, we don't know yet how that's all going to play out, how many people are really going to switch, but people really need that kind of information to make informed decisions about, based on price, knowing whether their same network of doctors is going to be available in another plan.
That's a very good point, Sarah, and we agree. And just last month, we put a consumer guide to networks out. You can find it on our website. We put a lot of time and effort in this. We worked with literacy experts. We worked with consumer groups. It's a very helpful guide and educational tool that consumers can use when they navigate different plan network configurations, and it provides them with the kind of information they need to make sure they're making the right choice. And we'll continue to focus on transparency because consumers have to know what plan is best for them. It's the whole part of value and, making sure consumers get the care they need.
I would just add quickly that the National Association of Insurance Commissioners is currently reworking its Model Act on network adequacy, which includes addressing the question of provider directories. And they have been holding 2.5 hours of conference calls every week, which I think is unprecedented in my experience. So I think the state regulators who are ultimately responsible for this are very aware that there is an issue here that needs to be addressed.
Commercial alert. The Alliance will be holding a webinar specifically looking at the soon-to-be, actually in draft form already has been released, new model regulations that the NAIC is developing in the area of narrow networks. And that is on the 18th, is it? 19th. You'll be getting a notification soon. Yes, go right ahead, ma'am.
Good afternoon. My name is Rhea Chakraborty, and I'm an attorney trying to break into health policy. My question builds upon several of the questions asked, but is specific to consumer confusion in anticipating their costs as it relates to the tax credits that they've been given. So as Mr. Jost mentioned, the Supreme Court did grant cert on this issue, and while you and I and many educated consumers may understand what that means in terms of impact on the decision and when it'll take effect, many other individuals may think that means I don't get a tax credit, in addition to the fact that the data that they had with regard to their taxes may change. And so I was just wondering what the efforts were that have been made to address this specific issue.
Well, I think there are representatives of the media in this room, and I hope they help get this message out, that the effect is going to be prospective rather than retroactive. People should go ahead and enroll. As to what the Supreme Court will do, I'm hoping that, obviously, that they conclude that the IRS has properly interpreted the statute and that solves the problem. If they don't, there are very serious problems that face not only millions of Americans who receive premium tax credits now and who would lose those, but really the non-group market in 2/3 of the states. We could, because of all of the carry-on ramifications of this decision, I think it's not just low-income people, it's not even just moderate-income people who could lose access to health insurance. It's virtually anybody who purchases health insurance that they don't get through their employer or a government program. And I think it's very important that people understand that this is very serious business. There is no easy fix. The administration, I believe, has properly interpreted the statute, but if the Supreme Court disagrees, this is going to be a national crisis, which I think Congress will have to fix.
If I could just follow up on that too, and just ask Tim to comment on, there's been a lot of talk about states just, if the decision were to go in favor of the plaintiffs, that states could just set up, that have federally operated exchanges could just go ahead and set up their own marketplaces.
Well, how much time do we have? I mean, in the first place, that's not, I mean, it would take legislation. It would take probably legislation. Some states it may be able to be done by executive act. There's a few states in which that's already been done. But states would have to affirmatively embrace setting up their own exchanges for that to happen. Secondly, under current regulations, a state has to give the federal government 6.5 months notice before it sets up a state exchange. And under current guidance, it has to do it by really by the 1st of May and have it approved by June 15th. So if the Supreme Court delivers its decision at the end of June, it would be 2017 before states could get state exchanges online.
So the first question is, where did those million people go that have left the exchanges? And a second question, which is kind of related, is the network adequacy. How confident should I be that if I sign up for 2015, the network that Aetna or Cigna or Blue gives me now will be exactly the same all the way through 2015, or will doctors get fired or drop out? Thank you.
Well, some of them may die.
What are you going to do about that, Mina?
I think that the reduction is pretty obvious, that any insurance company is going to have attrition over a year, and I think actually a 90% retention rate is pretty good. And also, you know, you have people who get a job, they get employer coverage. You have people who lose a job, they get Medicaid. There's just a huge turnover over the course of a year. And I was frankly surprised we still had 7.1 million in. Of course, there are new people coming on too, but I think that's a very good retention rate. And in terms of providers, I mean, that's a problem now with employer plans too that have networks. It's a problem with any network. And you can't be for sure that your doctor is going to be there.
So I would just add that the 8.1 million and the 7.1, it's not the same group of people. Insurance is constantly, it's dynamic. People come in and buy, people leave, people get married, they get divorced, they have children, they get a job. There are any number of reasons that would lead to a natural churn in the marketplace. So it's not that you had 8.1 million and then a million people left and you ended up with 7.1 million, because the composition could be different because of all of these different factors. So that's the one point that I would add.
I just wanted to follow up on that question too, with what we're projecting this year to understand. Both Tim and Mina mentioned the numbers of people that are expected to enroll this year and what the total number will be. And I think ASPE put out an estimate of 9 to 10 million this year. And I wondered if you could just unpack that a little bit and what that's comprised of.
Sure. You know, since we had experience from this past year, there was some data that could be used to be able to look at, of the addressable market, so you have people who are currently enrolled, and then you have people who would come in as newly enrolled. And for the newly enrolled, we're able to take the experience from this past year in terms of take-up rates of the percentage of people with various characteristics that took up coverage, to be able to get a sense of how many people may come in newly enrolled. And from the re-enroll population, there are several estimates that are out there, including from the issuer industry, and we were able to use that to get a sense of how many of the people currently in the marketplace would stay in the marketplace. And basically, those two figures together give kind of a bottom-up approach to give a sense of what may we be expecting this year, using data that was not available when initial CBO estimates were done. The other way to look at it is that you have a market that is growing, and there is a ramp up that's associated with the growth of any market. And from experience with CHIP and with the Medicaid expansion, you know, if you moved from a ramp up of 3 years to a ramp up of 5 years, that leads to a different trajectory. And doing each of those approaches kind of leads you to the same place in this 9 to 9.9 million range.
Okay. Jill?
Joyce Frieden, MedPage Today. As you all are aware, the open enrollment last year went, among the state-run exchanges, went better in some states than in others. You know, in Connecticut it went really well, in Maryland not so much. So I wondered if the panelists could talk about particular states that they might be looking at, and what would be signs that enrollment is going better than before.
It's got to be better in Oregon.
Yeah.
They've switched to the federal exchange, as has Nevada. And Maryland has, I understand, picked up the Connecticut software or website. So I think there are some states where we will clearly see improvement, but we'll have to see.
Oh, there's a related question on a card that panelists might want to address. And the specifics of the question have to do with the re-enrollment process, but I wonder more broadly what the application of the principle is, and that is that re-enrollment process going to look the same in a state-operated exchange as it will in the federally facilitated ones? For example, are they going to use auto-enrollment Tim was describing the sequence of how and when one would have to re-enroll in order not to be automatically re-enrolled. Are all the state exchanges going to do the same thing? Are they required to do the same thing? How many of the federal rules apply to them?
No, state exchanges can do their re-enrollment differently. Basically, in our regulation on this issue, states can provide their information on how they would like to do it and get approval to do it that way. So.
Okay.
And some states, as you said earlier, everybody's going to re-enroll.
Correct, Nevada
Yeah.
and Oregon.
So I have a question from the audience about what's contributed to what we're seeing in premiums this year. So why is it that premiums have increased moderately in so many states, or actually gone down in states? And what do we think is driving those changes? Even if you look at employer-based plans, if you want to even take a little bit more broadly, we've also seen a great moderation in premiums in employer-based plans. So maybe Dan would like to address that.
Sure, there are a number of underlying influences when it comes to premiums, and I talked a lot about it in my presentation. And in areas where there is substantial provider market consolidation and plans are unable to negotiate better rates for their consumers, you tend to see a correlation in those areas where there isn't market competition among hospitals. You have higher premiums, and that situation has to change if we're going to deliver value to consumers. So that's part of the equation. It goes right into the underlying cost of care. Similarly with prescription drugs, I mean, we look at Sovaldi, which came before Harvoni. Plans had to submit their filings and rates back in the spring of 2013, and health plans are competing. They're competing based on value, and value comes from low price, high quality, and that's why we have choice in this marketplace, because competition helps consumers. And so you do see variation by state. You see variation within the 501 market areas across the country because of these different types of factors that go into premium rate setting.
I guess I would just follow up too, just and ask Tim this, how important we think that the risk adjustment and risk, the 3 R's, or the reinsurance risk corridors and the risk adjustment provisions in the law have been in keeping premiums moderate this year.
Oh, I think they've been very important. And quickly, the reinsurance program provides reinsurance for high-cost cases for any plan in the individual market. The risk adjustment program moves resources from plans that end up with a low-risk population to those with a high-risk population. And then the reinsurance provides kind of a flywheel, so that if one plan gets their premiums way off one way, then they may either compensate or be compensated by plans that got their premiums off in the other direction. But I mean, I think Dan said this, that last year health plans were kind of throwing a dart at a wall. They didn't know exactly what the population was going to be that would show up and who they would end up insuring, and some big commercials didn't enter the market under those conditions. This year we're having a number of big commercials entering lots of markets, and that's increasing competition, but at the same time some plans that set their premiums too low last year are raising those. So there is a tremendous amount of movement in the market, and it's again very important for consumers to go back and shop to make sure that they know where their plan is at.
Jeff Raschetti here, healthcare lobbyist. I had a question for you, Mina, again on the coverage numbers. Your slide suggested roughly 7.5 million people enrolled through exchanges, roughly 8.5 million newly enrolled through Medicaid, and then the later slides suggest only 10 million newly covered individuals, the New England Journal reference. What happened to the 6 million people? Were they previously insured and headed to the rolls of the uninsured, or is it described through churn? Could you fill in the blanks on the coverage?
Sure. Part of it is that the 10 million number is not as recent as the other numbers that I provided. But also there are various aspects of the insurance market when you include employer-sponsored coverage, et cetera, that could be playing a role. But I think probably it's just that there's a difference in part just a difference in timing of the numbers.
So it would be accurate to say that 16 million people were benefited by the ACA in terms of acquiring coverage
Well, I mean,
or maintaining
I
coverage?
would venture to say that far more than 16 million people benefit from the ACA because there are so many other consumer protection provisions that affect people who already have insurance, get insurance through their job, et cetera. So I think it's kind of, you know, I do not think just the number of people enrolled in the marketplace, that's not the one and only measure of success for the Affordable Care Act. I think it is much broader than that, and I think looking at, for instance, the drop in uninsured is important just because that takes into consideration that there are many other ways that people are obtaining insurance as well.
And I'll just follow up on that too. In the Commonwealth Fund surveys, we asked people with both marketplace plans who newly enrolled and who newly enrolled in Medicaid, and about 60% of people with new plans had not had health insurance before they enrolled. So that gives you a sense of the share of people who were without health insurance before enrolling.
Yeah, and I mean, that's the other good point is that some of these people had insurance before and now likely have better insurance.
Right, so people shifted from individual, a substantial share, probably 20% in some of our data, which we're shifting from employer-based plans. So people do, and I think that's right now we might see during this open enrollment period, people who are also in their open enrollment period for their employers may be looking at whether or not they're paying a lot in their employer-based plans and decide to check out the marketplaces and see what's on offer in the marketplaces, and if they could in fact be eligible for a tax credit if they're paying too much of their income for employer plans. So you might see some shifting in that from employer-based plans this open enrollment period.
Okay. We have about 10 minutes left, and we're going to try to get to as many of the questions on the green cards that we have in front of us as we can. I don't think we're going to succeed in getting to all of them, so if there's something that you've written down that you absolutely positively have to have asked, you might want to repair to one of the microphones. In the meantime, let me just turn to one of these questions. Mina, a lot of commentators, and I think Tim mentioned it as well, have suggested that what happened last year was a fairly large enrollment of people who were motivated to get insurance for one reason or another, the famous low-hanging fruit. So you might want to describe what, if anything, HHS is doing to reach and convince those middle-hanging fruit people that they need to enroll as year 2 begins.
Sure. Well, with our very active outreach program, I mean, I think that there are still many people out there who are eligible for premium tax credits, who may be in plans and may not realize what opportunities are available that we can reach. And so it comes back to some of the points I made previously, that we are working very closely with our partners, with local media, radio, TV, digital media, events, and also reaching out across provider groups, churches, I mean, any number of community organizations to really get the message out. And again, I think having had the experience of the first year and having a lot of people who are enrolled, who are happy with their plans, helps to get more people who may have been reluctant or hesitant or doubtful, et cetera, to see there are people like me who were able to get quality coverage. And I think that that is a very strong message as well.
I wonder if the message is going to include at any level, whether it's with your partners or with some of the work you're doing directly, about the sticks as well as the carrots. We were talking to a member of Congress yesterday who pointed out that the penalty, that's not the proper term, the Supreme Court called it a tax, whatever the fee is, was going to go not to $95, but to a maximum of 2% of the person's income if they didn't have insurance coverage. And I wonder if that word is getting out to people as a way of convincing them that they need to look seriously about getting insurance for the first time. Is anybody talking about the carrots? and
One
the
thing I
sticks?
would say on that is that this year, and I think Congress intentionally wrote the statute so that this would be an educational process. The first year you get a little tap. Next year it's a much bigger tap, and by the third year it's a pretty big tap. But people are going to be getting their W-2s in January. They're going to go start working on their taxes, and they're suddenly going to realize sometime in February or March or April that not only do they owe $95 or 1% of their income for this year, but they're also going to owe $325 per adult, almost $1,000 per family if it's a large family, or 2% of their income above the filing limit for next year. However, the exchanges close their doors on February 15th, so people will not have a way of avoiding that penalty unless they qualify for a special enrollment period. I think that HHS has the authority to declare a special enrollment period for people who are going to owe the penalty for next year or who owe it for this year, and to leave that open a bit longer. And I don't see how that would hurt anybody, and I think it would be a way to bring a whole lot more people into coverage.
Is there something to consider in your deliberations at the department? Yes, Carl.
Carl Polzer, independent consultant, and you answered half of my question. So the IRS is really going to motivate a lot of the low-hanging fruit, the way the law is designed. And a lady in my church looks to me to be a sort of a navigator, because I know a little bit about health policy. And she works for H&R Block, and she says she hasn't received any guidance yet about, this penalty or this thing that she's supposed to deal with. And I wondered, how is the IRS going to deal with that on two grounds? One is, you already talked about, that they might be easy on people, but there's a certain disclosure element of it. Is there going to be a box I'm going to check to declare, if my coverage is creditable or whatever the word is? And then how is that enforced? Because certainly I'll make a lot of mistakes. There'll be a lot of people making mistakes one way or the other this year about, what do you mean by this coverage? How are they going to enforce that? So what if I put the wrong information in there? On what basis would I be penalized?
The forms are already online. The instructions for the forms are already online. The 1040 does have a box. You check that box if you've had continuous coverage, and if so, you just proceed. If you haven't, you will fill out a form called an 8965. The instructions are there online. And I've put up a couple of blog posts at Health Affairs explaining in some detail how it works. I think the people at H&R Block are very aware of this, and if she hasn't gotten instructions yet, she will, because they are going to be major players in helping people understand how all of this works. They and Jackson Hewitt and TurboTax and other people. But it's not easy. And the first year, a lot is going to have to be taken on trust because we don't have employer reporting in place yet, and there's some other issues.
How about health plans? Do they have any responsibility to notify their policymakers or their policyholders that, yes, the insurance that you get from us qualifies you, is a qualified health plan and meets the requirement of the statute?
That comes from the exchange, so that's the exchange responsibility.
I see. Okay. Sarah?
So I have a question on what I had mentioned, how important the deductibles are in my presentation, how important that people should really pay attention to what the deductibles are like. But will consumers have access to the information that they need about the implications of cost-sharing provisions of plans available on the exchanges? So will you be able to tell what your potential out-of-pocket costs might be over the course of a year, other than just the simple deductible or co-pays?
So one of the provisions of the Affordable Care Act made requirements on the summary of benefits and coverage that health plans must provide. And in that, they have to provide certain coverage examples that details out what are kind of the costs you could expect, and with the cost sharing in the plan that you're considering what would your out-of-pocket costs be?
Shout out to the DC Exchange. Our operations director was pointing out to me this morning, they have a couple of very good examples in their materials of just what you were describing. You know, how much is it going to cost if you have a baby in this period? How much is it going to cost if you're managing type 2 diabetes, that sort of thing. And it is very helpful to the people in our office in trying to decide as they did. We've come to the end of our time, and I apologize to those of you who have written some very good questions that we haven't had a chance to get to, but there are a lot of questions in this area, and we will try to keep up with this debate as it goes on and try to schedule programming that might be able to answer more questions. In the meantime, as you're putting on your winter coats to go outside, also take out the blue evaluation form and fill it out, if you will, so, to give us some feedback. Thanks to Commonwealth and Sarah for helping us put together and being part of a very useful program. And I'd ask you to join me in thanking the panel for a very enlightening discussion.